Hello, this is Christine Gauthier, and we are going to go over the content for newborn screening. Essentially, we will have an overview of what newborn screening is. We'll talk a little bit about where newborn screening has come from, where it is currently, and where it's going in the future. We'll go over Colorado as an example for how they do newborn screening and their procedures, and discuss some additional considerations. So newborn screening basically is testing every newborn for certain harmful or potentially fatal disorders that we don't otherwise know about when a baby is born. The majority of these conditions don't have any symptoms when babies are born, so we don't typically see anything going on with the baby. If the conditions aren't found early, they can have pretty severe consequences, including things like severe illness, mental retardation. We may see developmental delays, seizures, chronic illnesses, and even in some cases, death. So obviously, early detection, diagnosis, and intervention is the key here. So newborn screening was first developed in the 1960s, and the first test really only screened for phenylketonuria, or PKU. PKU is a metabolic disorder where individuals don't have an enzyme needed to process the particular amino acid, phenylalanine, and that amino acid is necessary for normal growth in children and normal protein use throughout life. When what can happen is it will build up and cause damages in brain tissue and substantive developmental delays. So as of recent, we've had some more advances with newborn screening, and we've had expanded screening for genetic disorders, endocrine disorders, metabolic disorders, and then technology has expanded such that we actually are using tandem mass spectrometry, and that technology was actually added in Colorado in 2006, and it included the detection of 23 additional metabolic disorders specifically. So current screening practices, unfortunately, the federal government doesn't have any set national standards. So really, screening varies from state to state. And the majority of them are determined by individual state public health departments. Now, most states currently screen for more than 30 disorders and offer the expanded screening panels. Testing is often offered based on a cost benefit, and that includes several considerations. So one of them is the risk of false positives, and if you have a false positive, certainly there's associated worry and whatnot with it. Also, the availability of treatment. So do you test for something that's rather expensive to test for that we may not have any available treatment options for? And then also just the cost. So does the cost of the test outweigh adopting that screening? I apologize, my phone is ringing. Like I said before, most states have mandatory newborn screening programs, but they vary widely within the states and across the states. So majority of states have expanded their screening, and they're using tandem mass spectrometry. And most of them can screen with that technology for more than 20 inherited metabolic diseases just with 1 drop of blood. And again, when we go back to the states, follow-up diagnosis and treatment varies between the states, and obviously it's individualized between the states for what they're screening for. Then the follow-up testing, who does it, what laboratory does it come from, and further diagnostic studies or testing may vary from state to state. Again, who does those, what they cover, what they don't cover, and then whether or not there's treatment for any specific disorders that are offered through state programs or not. And along with the treatment goes any ongoing evaluation or management of those disorders. And that, again, varies from state to state. Now, when we look at current screening practices, this gives you an example of sort of the universal panel that the majority of the states have adopted, and these are the things that they almost universally screen for. The link on the bottom of the page will take you to the National Newborn Screening and Genetics Resource Center, If you pull up that page, there is a link on the right side, and you can download a PDF that was just updated in January of 2013, and it gives a state-by-state report of what they screen for on a state-by-state basis. So that's a great resource. Now, if we look at Colorado as an example, I realize that there's a lot of information on this slide, but I thought it was easier to have it on one slide rather than break it up. But it gives you an idea of the expanded newborn screening panel that Colorado offers. And you can see that there's quite a few different disorders that we screen for in Colorado. And if we look at Colorado and their screening practices, Colorado does 2 newborn screenings. The first screening is as late as possible for discharge and no later than 48 hours of age. And ideally, babies need to be at least 24 hours of age. This is more accurate for some of the disorders, particularly metabolism. The second screening is typically done between 8 to 14 days after birth, but it can't be done less than 72 hours or greater than 30 days after birth. And the second screening is, you can see here on the right side, it lists what is screened for in the second screening. Now there's a link on the bottom of the page that will take you to Colorado's newborn screening site, and it essentially gives you all of this information and lays everything out as to policies and procedures that are in place for newborn screening in Colorado. And many of you may have seen, may have done, and may be familiar with collecting newborn screening samples, but those of you that aren't, typically it's done with a capillary blood sample, and the state should have a specific blotter paper that it's done on that has a lot of information in terms of the baby, the parents, birth weight, date and time of birth, so we know how old the sample is. And you can see the picture on the right, on the top of the right, shows you an example of a blotter paper, and typically there are circles on the end of it that need to be completely filled to ensure that you have a good, accurate sample. And there's just a picture of an empty blotter paper down on the bottom of the right-hand side. And then the other picture shows you where to obtain the sample on the infant's heel. And the most important thing is typically we need to have an adequate sample. If you don't have an adequate sample that saturates all of the circles on the blotter paper, oftentimes you will get a report back that says that it's an insufficient sample. So that's one of the main things, is to make sure that you have a good sample. Now, some additional considerations that we sometimes need to think about and we come across as midwives or nurse practitioners in our practice are things like family history and extended screening. So, for example, if you have a family that has a history of a particular disorder that isn't offered in the routine panel that your particular state provides, then you might need to find out where it can be done, how much it will cost the family, treatment options, follow-up, and those types of things specific to where you live. Another consideration is deliveries outside of the hospital setting. So more and more we're seeing home deliveries and other things like that. And if you actually look on the Colorado's website, they have specific instructions in terms of who is responsible for collecting those samples. And again, that's where you need to know what your state's guidelines are. So another thing to consider is parental refusal. Certainly parents can refuse to have these tests done. That might be something that you might come across, and you might need to provide some education and some counseling to parents that may potentially refuse to have a PKU, or a newborn screening panel done. And then really the take-home message here is state screening practices, that they really vary widely. So essentially the bottom line is that you need to know your state. You need to know the screening panel. Colorado does 2 screening tests. Many states only do 1. So when they're being done, where they're being done, and the schedule for doing those. So in Colorado, the second screening needs to be done before the baby is 30 days old. And then also the screening policies and procedures. So the type of collection, paper or whatnot that the states use, how they're collected, if it is a home delivery or something like that, and what the reporting method is. So does the state report it out to the primary care provider's office? Most states use the state lab to do the testing, but again, some of the states contract out with private labs. So who's getting the results? Who's following up on those results? If it's a child that they're looking at for one of the diseases that they're screened for, do they need to be rescreened? Do we need to do further lab testing, referral to specialists, those kinds of things. So also knowing follow-up, diagnosis, and treatment specific to the state that you're in. And then another thing to consider is genetic research and future implications. So where are we going with newborn screening? On the bottom of the page is actually a link to a report where they're developing and adopting a universal screening pattern, and there's an ongoing dialogue as to where that will go in the future. So that may be something that may change as time goes on. And here's just a few references that you may want to look at for a little bit more information. If you want more information on any of these specific things that are screened for in the newborn screening, the top resource from the American Academy of Pediatrics is an excellent article. It discusses all of the disorders that are screened for in depth. So I would encourage you to take a look at that. Thank you very much.